Bush. I'm a Senior Director at Management Sciences for Health, and we host the Secretariat of the Civil Society Engagement Mechanism for UHC 2030. I'd like to kick us off this morning with an introduction to the event. We're very fortunate to have Marjolaine Nicode with us from the UHC 2030 core team. Marjolaine, would you like to give the opening, please?
Okay. Hello, everyone, and welcome to our webinar on accountability for health equity. This is the theme of a recent IDS Bulletin. So the launch of this bulletin is very exciting. It provides an opportunity to convene partners and discuss some of the key messages and findings from the bulletin, providing a platform to learn and share. And as many of you may be aware, UHC 2030 is committed to strengthening accountability for UHC in the context of the health SDGs. And in this context, we are trying to promote a more coherent approach to accountability across health. A key priority for us is to strengthen capacities of different actors, including CSOs, media, parliaments, for social accountability, so that the experiences and lessons emerging from the IDS Bulletin could also inform how we approach this. So if you are keen to engage in our work on accountability, please get in touch. At the end of the presentation, you will see contacts for UHC 2030, and you're more than welcome. There is still a lot of work in progress. We need the contribution of many of you. So I look forward to today's discussion, and I will be here for questions and answers at the end. Over.
Excellent. Thank you, Marjolaine. Just a question to my tech team. We seem to have possibly lost the PowerPoint.
Yes, it looks like Leroy took control of the presentation. So Sarah, since you're the host, you can actually take control back.
Thank you. Thanks so much, Marjolaine, for the introduction, and thanks to all of you who are joining the webinar today. So, as I mentioned, I'm the moderator. Before we get started with introducing the panelists that we have with us today, I wanted to give a few very quick words about how the webinar is going to work. As I mentioned already in the chat box, all participants will be muted, but we do encourage you to submit your questions at any time during the presentations that are going on. Our team will be helping to compile those questions and prepare them for the Q&A session. As I also mentioned, if you have any technical difficulties, you can use the chat box to connect with our team, and they can try to help you behind the scenes. Also wanted to share that a recording of the webinar, including the presentations, will be available on the UHC 2030 website in the coming days if you'd like to share it with other colleagues or review it again. Also, we'll be having some of our colleagues, and we encourage you to join us in live tweeting, sharing the outcomes of this very interesting webinar today. You'll see here on the screen some of the hashtags we suggest you use, as well as some of the handles for the participants. And as you've seen from Eliana also in the chat, there are some instructions about not clicking on your share screen button so that we can continue to control the PowerPoint. Now it's really my pleasure to introduce the speakers for today. We're very fortunate to be joined by Erica Nelson from IDS, who is the lead editor of Accountability for Health Equity, Galvanizing a Movement for Universal Health Coverage, the IDS Bulletin we're here to discuss today. And we have two presenters who are contributors to the Bulletin, representatives of civil society who are deeply engaged in UHC advocacy in their countries. Very pleased to welcome Denise Namburete from Untitled Health Communication in Mozambique, and Walter Flores from the Center for the Study of Equity and Governance in Health Systems in Guatemala. So let's get started. Each speaker will make a brief presentation, and we'll have plenty of time for Q&A. Erica, you're up first. Please go ahead.
Okay. Hello, everybody, and thank you so much to all who've showed up for this webinar today. It's really exciting to have this opportunity to share something that I've been working on for quite a long time, together with a whole host of both colleagues within IDS as well as contributors and collaborators who've made this particular issue of the Bulletin possible. But I just first wanted to say a few quick words of thanks to the people involved in making this webinar happen. One is Laura Brearley from the UHC2030 core team, who could not be with us today, but she was really key to basically making this webinar happen, as well as Amy and Sarah at MSH, who've been so helpful and positive in the planning and preparations, and of course my colleagues at IDS who are squirreling around in the background with tweets and counter tweets. And the HSG team is Tom Barker and Corinne Gatelier, Leah Murphy, and Sophie Marsden, who all helped in communications related work and engagement work connected with this bulletin. So I'm going to keep my comments brief because what I'm most interested in happening today is hearing what questions people have and how people have reacted to Denise and Walter's presentations and the few brief words I'll offer. But I want to give you some context as to why we're here today. Basically, how this came about is in July of last year, IDS hosted a workshop that was in collaboration with Future Health Systems, the Impact Initiative, Open Society Foundation, Unequal Voices, and Health Systems Global. And the objective of this workshop was to get people to really generate new thinking as well as practical approaches to improving accountability in health systems. And the workshop was centered on questions of, at its heart, questions of politics and power, and how relationships of power play out at different levels within health systems and beyond health systems in ways that ultimately create barriers to achieving greater health equity, which is, the core objective that gathers us all here together. Sarah, can you go to the next slide, please? Sarah, I have no control over the PowerPoint, or whoever it controls it can go to the next slide if they'd like.
It's
Thank you. So the word accountability is a really slippery one. It's a little bit unwieldy, and it's become a term that means a lot of different things to a lot of different people. The workshop itself was a chance to gather together practitioners, researchers, policymakers, all working in favor of health equity to talk about what it means to them and how it can be used to ask challenging questions about the nature of power in what we call global health. And you'll see, I don't know how closely you can actually read this table of contents, but it's just to give you an idea of the real diversity of approaches, of thinking, of experience that is reflected in what people have written and contributed in a visual format to this particular issue of the bulletin. The workshop raised a lot of questions that were taken up and expanded on that you can see here. And but these are it's the beginning of a conversation. This webinar is, an opportunity to engage and to have dialogue. I see the bulletin hopefully is spurring further conversation and dialogue about some of these really challenging and complex issues in health systems and specifically to the question of how do we go about achieving UHC 2030 and what do accountability approaches lend to this process. There's a lot more than I'm going to be able to summarize in this brief introduction, so I'm not even going to try, but what I want to encourage you to do is to go and look at the bulletin. It's entirely open access, so there's no paywalls. Anybody can see the content and share the content. If you could go to the next slide, please, Sarah. Thanks. So just to give, again, an overview before I turn to Denise, there's three core themes that emerged from the July workshop and that are expanded upon in this issue of the bulletin with regards to accountability for health equity. And the first theme is this question of the nature of how accountability politics play out in time and over time, and the importance of taking a long-term approach to change, both to understanding change and to affecting change. The second theme was this question of these contested politics of naming and measuring accountability, and more specifically, the intersecting dimensions of marginalization and exclusion that are missing from current debates. And what I mean by this is that, this word accountability in English is quite slippery. People, use the term and mobilize the term in a lot of different ways. They also measure what it means to achieve greater accountability in different ways. So that's sort of the middle section of the bulletin is looking at these questions. And the final section of the bulletin asks this question about the shifting nature of power in global health and new configurations of health actors, social contracts, and the role of technology. So it's about not only examining these relationships of accountability as they have developed over time, but trying to imagine where we go from here in a future that is fast changing, and in relationships within global health that are they're incredibly dynamic. For the purposes of today's webinar, we're going to focus on the first theme, accountability, politics, and time. And all I want to say about this here, because Denise and Walter are going to expand on this in greater detail, is that the question of how to strengthen accountability relationships and processes in favor of greater health equity it's not a new question. The language of accountability may be new in how it's deployed in global health circles, but the challenge of holding power to account is not. And I just want to reflect briefly on, we're on the eve of the anniversary of Alma Ata and the promise of health for all by 2000. It's the 40th anniversary. And I think it's really important in light of this renewed commitment to universal health coverage by 2030 that we take this longer view in our attempts to understand what has been working, what hasn't when it comes to improving health equity. It's also vitally important that current efforts to change or shift existing accountability relationships and health systems recognize that only through long-term commitment will the change that we seek become possible. One last point before we move to Denise. This bulletin, for the first time in the history of this particular journal, includes both film and photography contributions. The rationale of this choice was to go beyond sort of the typical text-based content of academic journals and to engage with new audiences. One very clear point that came out of the workshop in July and is explored in greater depth by contributors to the issue is that there's a tremendous diversity of accountability strategies, meanings, and practices. And we felt that by opening up the IDS Bulletin to include visual content, we'd be opening up to new ways of looking at and therefore understanding the complexity of accountability in health systems as they exist off the page. So with that in mind, I'm going to turn to my colleague and collaborator on Unequal Voices project, Denise Namburete, who's going to talk about her contribution to this issue. And a final word of thanks as well to my co-editors who are not part of this conversation today. I mean, they may be listening in, but I'm doing the talking. So Jerry Bloom and Alex Shanklin were my co-editors of this bulletin, and they deserve equal, thanks for making this happen. So Denise, on to you.
Thanks very much, Erica, for that really helpful overview. And thank you, Denise, for joining us. Everyone, I encourage you to take a look, as Erica was saying. We'll share some of the links at the end to the open access, and really encourage you to take a look, if you haven't already, at the YouTube piece that Denise has prepared on holding a health system to account, Voices from Mozambique. So Denise, I'd like to welcome you to share some of your experience today and to address this question that we see on the screen. If you can talk to us a bit about, from your experience, what you see as the greatest challenge to linking accountability demands at the local or community level with accountability demands at the national, regional, or global level when it comes to the Mozambican public health service delivery. Over to you.
Thank you, Sarah. May I ask you to go to the first slide, please? I think we all agree that context matters when it comes to accountability, and maybe I should start by giving you just a brief context of Mozambique. As you know, Mozambique remains one of the poorest countries in the world, where 69% of the population are classified as poor. So recent economic crisis to the health sector actually highlighted the country's fragility in terms of investment towards universal health coverage. Health inequality is increasingly growing. So some of the issues that this video that Erica mentioned tries to explore is to raise questions about, what happens when the social pact is broken. In the case of Mozambique, the social pact towards universal health coverage actually dates back to 1975 with independence. And since then, the political promises of health were reaffirmed over and over in all electoral disputes. The ruling party, who has been in power for 40 years, failed in keeping to these promises. The state is unable to provide services to all and, in the quality that citizens deserve. So there is a strong belief that investment for increased accountability can play an important role in steering the country towards reducing health inequalities. So therefore, in the last 5 years or so, we have been seeing a proliferation of citizen participation, transparency, and accountability initiatives at community level, mainly driven by civil society organizations aiming at influencing quality of the services, demanding transparency and accountability, and to some extent, these social accountability initiatives at local level are encouraging for several reasons. I believe because one, they demand improvements in the service provision at facility level, but they also catalyze participation and engagement of citizens in demanding public health authorities for information and justification of their actions, and in some instances, sanctions for health rights violation. They've been activated. But there is not so much happening in terms of influencing structural issues, in terms of scale and sustainability. So I think most of the time the gains are very localized and unsustainable, with limited space and opportunities for scale up and links with the national level. And I believe we need to be less static and more strategic in engaging with the government in planning and budgeting, in decision making, in the formulation of policies. And I'll get back to this later on with a few experiences from Mozambique. I think in response to the questions you raised around challenges in linking accountability demands at community with national level, I think some of the challenges include the fact that civil society in Mozambique lacks capacity and ability to influence structural issues and policies at the national level. We have been seeing more lately this capacity being developed, but it's still not enough to influence in a sustainable way. We also see an ability of civil society to use invited spaces where plans and policies are formulated. And these spaces, I believe, represent an opportunity for CSOs to raise their accountability demands and exert policy influence. Another challenge is the fact that Mozambique is highly particularized and centralized state. So in talking about accountability and politics, I believe that decentralization is key to bring closer health users and health authorities, therefore allowing for greater proximity and space for dialogue and influence. One last challenge that I'm bringing here is that in probably one of the major lies within the relationship between donors and government. Mozambique is one of the poor countries, as I said, and in the last 30 years or so, received more aid for health than most of the countries in the world. Yet we are far from reaching the SDGs or achieving universal health coverage by 2030. For all this period, accountability tools, for all this period that donors have been funding the health system, accountability tools, the systems, the process, the relationship between donors and government were strengthening. Donors were basically funding, and the government was accountable to donors. And this resulted in a huge gap in terms of accountability towards citizens, was not seen as a priority at all. With a global reduction in aid, Mozambican government is forced to increase domestic funding to compensate for the reduction in aid, which is probably the best thing that could happen in the case of Mozambique, where lack of leadership and ownership left accountability functions unaccounted for. So I think with this increased investment of domestic funding comes the need for citizens and CSOs, to participate in governance and demand transparency and accountability and influence health policy formulation. So despite all these challenges, there has been a growing effort of a few local organizations, still very incipient, in strategically linking the accountability demands from local level with the national level. For example, data generated through the use of social audit tools are being used to inform policy influence at the nation level. I'll give you the examples. We have last year looked at all social audit interventions in Mozambique and found that there are few commonalities around, perspective of citizens in terms of the quality of services they receive. And one of the most critical issues was legal payments in health facilities, which is it's a violation of the Mozambican constitution, which says access to public services, to health public services is free. So we have advocated with the Minister of Health, and we managed jointly to design a national strategy against illegal charges in healthcare. And this strategy is now being implemented by the National Health System, and you can actually see references to it by health professionals in the video from the IDS Bulletin that Erica just mentioned in the beginning of this session. Another example of strategic use of accountability findings demand, at the national level, has been the use of data to influence public finance management. Basically, what CSOs have been doing is to share accountability demands from the local level with members of parliament, and as they conduct monitoring visits to their constituencies, they're able to monitor and request for justification, around the demands. CSOs have been also analyzing budgets, state budget plans, national plans, budget accounts, and use the social accountability demands from local level to build a body of evidence to support arguments in positioning papers. And these positioning papers are then shared with political parties, stakeholders, government, the parliament, also with account codes to inform and influence discussions of policies in the parliament. So there are some very new initiatives of doing in a very strategic way, in demanding and influencing policy in a very strategic way. And some of the gains, I'll mention just a few, have been the increased domestic funding contribution for health and social services. We also saw, as a result of these demands, of these link cuts in high-level public official benefits and reallocation of these resources to critical social areas. There was last year an interesting experience around institutionalization of citizen voice as part of the National Health System Performance Appraisal Framework, and more recently, inclusion of community scorecards in the National Health System as a tool for monitoring health user satisfaction. So what we see as challenges at national level is that the greater the ability of CSOs to voice their accountability demands, the greater the reprisals from certain, let's say, anonymous factions of the state. I believe you have been probably following the increase of repression against citizens, academics, civil society, and media in recent years in Mozambique. The cost of participation in policy formulation and governance, it's becoming very, very high. And I think this does not yet stop citizens from speaking up and engaging with local authority. So basically, I think investing in universal health coverage in Mozambique demands major financial domestic resources for health, which means less resources for certain areas such as military, defense, severity, which absorbs a lot of resources in the case of Mozambique. So in the context of social and political unrest, it becomes very hard to bargain for increased resource allocation for health and demand the government to be accountable for the policy choices they make. So I think probably these are some of the challenges that we face in Mozambique in trying to be strategic in the way that we use social accountability demands from the local level to the national level.
Thanks, Denise. That was an excellent overview, and really, again, encourage everyone to take a look at the YouTube video, which addresses some of the questions you'll see on the coming slides. We didn't advance them necessarily while you were speaking, but addresses the challenges of sort of lack of responsiveness in the health system, as Denise was saying, sort of, what are the costs and the burden on the population, as well as looks at, as you see on the next slide, what happens with lack of availability of medicines and how issues around corruption and lack of accountability prevent access for all and prevent achievement of health for all. Thanks so much, Denise, for sharing that. And I think your lead in your discussion sort of around the cost of participation becoming high and what it means to have, greater voice for citizens, what the result is then sometimes in the health system is an interesting lead in to the presentation of our second presenter. We're very pleased to welcome for the second presentation Walter Flores from the Center for the Study of Equity and Governance in Health Systems in Guatemala. Walter has contributed a piece to the bulletin entitled Health Accountability for Indigenous Populations, Confronting Power Through Adaptive Action Cycles, which is co-authored with Alison Hernandez. And Walter, we are looking forward to hearing from you this morning about your piece and about why you think a cyclical or long-term approach to improving health accountability mechanisms and outcomes for indigenous populations in Guatemala is necessary, and how might this approach be relevant to other marginalized groups that those on the webinar may be working with. Over to you, Walter.
Great, thank you. I would first like to make some introductory remarks about implications that within the broad UHC goal and the SDGs, we should work to reduce inequities and that no one is left behind. First, we must understand that the fact that there are still large inequities both within and across countries and that some population groups have been left behind is no accident. Rather, this has been happening either because of economic and social policy design or a lack of interest by those in power in implementing interventions that would benefit marginalized populations. Just let me give you some quick examples. There are many countries that, although having strong health systems and near universal health coverage, they refuse to provide the same level of medical care to the rest of the population, to migrants or refugees. We also have countries that, despite evidence of existing inequities, they continue providing a higher share of public resources to urban populations and better off populations to the expense of rural populations and the poor. Also, it is not true that people have been left behind because they are hard to reach or hard to identify. I would argue that in most countries, you can ask local residents, who do you think is socially excluded or marginalized or oppressed? And very readily, they will tell you indigenous, aboriginal people, ethnic minorities, migrants, refugees, people of different sexual orientation, the poor, among others. So, I argued that they are still being left behind because they continue being ignored by those in power, not because that they are hard to reach, not because they are hard to identify, just because they continue being ignored. So, I would also state that the most damaging effect of marginalization is the inequity of power, which is manifested by the gross violation of human rights, attacks to people's dignity, and the lack of political representation. Another problem that is very common is assuming that marginalized populations are passive subjects, that they will be sorted out by privileged professionals. This doesn't help at all if our intention is to facilitate the empowerment of individuals and population groups. So my proposal, based on our more than 12 years effort in Guatemala working with indigenous population, is that in the process of reaching out to marginalized populations with public services, we should also facilitate conditions for the legal and political empowerment of those populations. Once they start becoming subjects of rights, they, together with progressive officials, providers, and organizations, also start to tackling structural determinants of marginalization. So please, if you can start with the images now. So about the question, why accountability action cycles? I think we all would agree that laws are important, and yes, they are important, but in a context of deep marginalization, exclusion, and racism, such as the context of Guatemala and its indigenous population, laws do not generate changes by itself. The legal framework, rules, and regulation must be enforced, and even better if it is done by those populations directly affected. This is what we call accountability. We conceive accountability actions as cycles in which first communities learn about the rights and responsibilities, what is a public policy, and public services. Second, they collect and analyze evidence about problems within public services. Third, they engage with public officials to present the evidence and negotiate action plans to resolve problems. And finally, they verify that problems are actually resolved. This is a very flexible and engaging process. So, accountability cycles aim to tackle the barriers and bottlenecks that affect healthcare services. These action cycles are led by community defenders for the right to health, who are all those people that you see in the images that are volunteers elected by their own communities to carry out three main functions. They carry out rights literacy to their own communities. They also collect evidence and complaints about problems in service delivery, and also they represent a patient when there is a serious violation of rights, such as a discrimination, denial of services, or demands for illegal payments from a service provider. These community defenders engage not only with health officials, but also they engage with parliament, with the ombudsman, and also with the judiciary system when needed. So let me give you some quick examples about some accountability cycles. For instance, for a common problem of lack of emergency transport, after identifying what are the bottlenecks for not having emergency transport, the solutions involve arrangement with local government and health authorities to finance the petrol of the ambulance. And to tackle the recurrent drug stockouts, whenever the Ministry of Health facilities face stockouts, municipal governments provide supplies until the next restocking of health facilities occur. I would suggest, if you can look at the article that we published, because there are many more examples there, because of the short time, I'm not going to give more examples, but I just want to make emphasis on what does it mean for UHC and marginalized populations. So at the moment, we have been implementing this approach of accountability action in 35 municipalities, which is about 10% of the territory in the country. In all of these municipalities, there have been improvements in the responsiveness from local health services and also increased supplies and other essential resources. But most importantly, the indigenous communities who are the ones using those services have been at the center of this achievement. When we first started our work, these communities had little contact with government officials and public services, and there was distrust between service providers and communities. Several years after, communities are actively engaging with authorities at different levels. This is an example of social inclusion and also achievement towards a more democratic governance in the health system. But despite this achievement, I must clarify that we are yet to resolve the structural causes of recurrent stockouts in rural areas or insufficient allocation of resources to rural areas or abuse and discrimination by providers and illegal charges to indigenous patients. But currently, community defenders are organizing a network and they are building alliances to tackle the structural causes with the following actors. One is civil society organizations, many of them working at national level, but also they are building a relationship, and they already have a relationship with several UN agencies present in the country. They also engage with progressive politicians, and very importantly, they work together and they are building alliances with public officials, not only from the health sector, but also from the judiciary, with the ombudsman and others. So everything that I have just mentioned is an example of galvanizing efforts towards UHC. So I would like to conclude with three points. The first point is that marginalization and exclusion have structural causes that must be tackled within and beyond health system. This requires long-term and sustained efforts instead of a 3 or 5 years project or initiatives. My second point is that leaving no one behind and universal health coverage are just nice slogans if we do not seriously tackle the structural barriers that create marginalization and exclusion. And finally, UHC outcomes should go beyond improved access to services and financial protection. UHC outcomes must also seek the social, legal, and political inclusion of disadvantaged populations. Thank you.
Thanks very much, Walter, for that excellent presentation, and we also enjoyed seeing some of the images of the work that is currently being done in Guatemala by those community defenders, the network building, and the engagement with those like parliamentarians who are in those structures of power. Thanks again to Erica, Denise, and Walter for those thought-provoking presentations, and thanks to all of you for listening. We now have plenty of time for engagement around question and answer. I see there are some questions starting to come. So as a reminder, participants in the webinar are muted so that we can avoid any background noise, but you are very much encouraged to share your questions and presentations in the chat box. You're also seeing on the screen here now a reminder that all of the articles and the multimedia content in this IDS Bulletin is available open access. There's no firewall, no need to pay. So I really encourage you to read through the bulletin yourselves and to help promote and share this. The link is available there. I've also shared in response to a question the direct link on YouTube for Denise's excellent contribution to the issue. So we'll start now with a couple of questions. Unless, Erica, just given the sort of presentations from the two panelists, do you have anything you want to add on the sort of overall bulletin perspective, or are you ready for us to move on to the Q&A?
I think we should move on to the Q&A, and I can weigh back in if necessary on, if questions come up that are related to articles or contributions that, Denise and Walter weren't directly involved in. I'm happy to try and field that. But I think let's hear what people have to say.
Okay, great. And as one of my colleagues has reminded in the chat, make sure when you're sending the chat that you're sending it to everyone. There's a little drop-down box so that everybody can see your questions. We'll get through as many of them as we can today on the webinar, but we'll also be collecting them. So if we don't get to your question, then the panelists have very kindly agreed to follow up with speakers directly. I have also received some questions about how people will be able to access this recording of the webinar afterwards. Again, it will be posted in coming days on the UHC2030 website, and we'll be sure to promote that link via our social media feeds so that you can share it or watch it again, because it's already been fascinating. So let's start with some questions. A couple of questions coming in here for Walter. The first one about targeting marginalized populations. And if you could talk a little bit more, I know you addressed some of this in your article about how you counter those existing social and cultural norms, particularly at the centralized level. Would you like to respond to that, Walter?
Yes. Thank you for the questions. Yes, in the article from the title, which is Confronting Power, we describe that process, that Guatemala has very progressive legal framework, but most public officials choose to ignore the framework. So as I said in my presentation, it requires an enforcing of that framework. So that means that it is not free of tension. There is a lot of tension there, but having this legal support, the back of the law, is very important. Also, we have to be very clear that it is not only about training marginalized communities about their own rights. That would be the first step, and I would say the easy one. what is the key component of these efforts of tackling power and tackling marginalization is the continuous accompaniment, the continuous technical support from organizations like ourselves that can provide not only technical support on public health, but also interdisciplinary support, something of that I described in the article. For instance, our interdisciplinary team provide technical assistance to these communities through lawyers, through political scientists, anthropologists, and journalists. So engaging with these cultural norms that you're saying, with these powers, with maybe opposing marginalized population, require strategies of identifying what's happening when you challenge in power and how you reorganize yourself, when you have to use the legal framework, when do you have to use the media, when you call to a press conference, and when you even have to do a street protest led by those communities being marginalized. So all of these are different legitimate strategies that you have to use when you're confronting power. And also, I will send you back to our article. We describe that. And also in the article, there are links to some of our websites where we have a lot of audiovisual materials that explain these different strategies.
Thanks, Walter. And for everyone who was asking, the direct link to Walter's article is contained here in the chat box. I think you touched a little bit also in that answer to some of the other questions that are coming in around your presentation, something in terms of sort of how you're doing that engagement and referring people to other resources to learn a little more about the community defenders and the work you've been doing. There's a slightly different question here about how you work with those indigenous groups, and particularly issues of promoting gender equity and women's leadership among indigenous women's organizations in Guatemala. Do you have any particular experience to share there? And if so, how you're addressing those are also social and cultural norms around gender equity and women's leadership?
Yes, we have the network of community defenders at the moment is made of 160 defenders, all of them community volunteers elected by their own community. About 40% are female leaders elected by their own communities. And we are very much aware that it is not the same kind of conditions for a male or female leader. So through our 12-year process, we have been learning also what sort of challenges do female leaders face and what sort of condition we can facilitate for them to overcome those barriers. For instance, when we provide training, many of the female leaders, to all the community leaders, we provide subsidies for food and transport. But female leaders qualify, and also male leaders, whoever needs it, can apply for subsidies for children that they cannot leave behind, that they wouldn't be able to come to the training because of they cannot leave the children behind. So they can apply and inform us that I'm going to bring two kids. Would you please give me subsidy for my kids? And we provide that support as well. Also, we provide extra support when specific women which have been showing more leadership want to do specific activities of mentorship to younger female leaders. So we have started a specific project which provides small grants to female leaders that are more senior to provide mentorship to newly female and younger leaders that have joined into the community defender network. So we have been implementing this kind of action to promote, as I'm saying, a larger number of female leadership within the network, but also, as I'm saying, trying to identify what would be a barrier for a female leader, that may be causing an effect of her more active participation. I'll leave it there.
Great. Thanks, Walter. That's excellent to hear about the particular engagement and considerations of ensuring engagement of both male and female community defenders. I wanted to actually pose a question to Denise. I thought it was really interesting when you were talking about the efforts to institutionalize citizens' voices, the work around community scorecards, et cetera, that greater voice is beginning to equal greater reprisal. And the cost of participation can become high. I wonder if you could talk about what that's meant for civil society members or for citizens, and how you all may be working to try to address that. It doesn't sound, luckily, like that fear of reprisal in either of your countries is scaring people off from engaging. In fact, perhaps it's encouraging them. But how do you address that in the Mozambican context?
Thank you. Can you hear me?
We
Hello?
can, yes. Go ahead, Denise.
Oh, great. Thank you. Thank you for your question. It has been very, I think it has been very challenging in the last 3 years, especially since Mozambique took this the government of Mozambique took this illegal debt. We have felt before the issue of the illegal debt came to public, we were already feeling the closing space, the government closing the space of civil society, but it became more and more strong in the last years. So what we have been trying to do is to work more from within technical working groups, formulating policies, than using confrontational approaches. So trying to find champions within the system, champions within, the sector, and there are many, and we try to channel our demands through these champions. And that has been, proving to work in this context of reprisal. And we do believe that it's going to, this climb of repression is going to increase probably, because we do see a growing capacity of citizens as well to use social media to demand accountability. So at the same time that we see this space of civil society being closed, we also see the government trying to control more and more the use of social media, to control and monitor, potential voices before they actually raise up to the public. So I think we need to continually innovate in terms of the way we influence decision making, so that we keep focus on structural and political causes affecting, inequalities and access to health. But then definitely, I believe we're going to be even more creative later, because it's proving to be very challenging.
Great, and Denise, while you're on the line and we have you unmuted, another question has come in for you. Really interesting question. You mentioned the use of data to influence public management in your presentation, and one of the participants is asking about what data is collected, how is it collected, and how is that being used to advocate for accountability around UHC. Could you speak to that?
Yes, we have experience in using budget tracking at local level, district level, tracking expenses from the health sector specifically at district level, analyzing and prioritizing that data, and deciding which issues, dividing which issues actually can be resolved at local level, which ones demand structural changes, policy changes. And we take these issues to national level. And certainly we have to provide the evidence and prepare all this information in terms of, positioning papers, and present these data to convince and advocate for policy changes. So I'll give you some examples. One of the challenges that we face in Mozambique is the fact that, as I said, the country is highly centralized. So we had to use budget tracking data to show how the fact that the system is centralized and results in terms of access to health to happen at district level. We have 148 districts, and all of these districts don't have access to managing the accounts. They have to wait for the national level to access and manage the accounts. So we've been advocating at central level for decentralization of the budget, but also for to have a budget, state budget that is done based on programs and policies, so that later on we can monitor the implementation of the budget and assess to what extent resources have been used to advance a certain program and policy. The way the budget is designed now doesn't allow us to have that evidence and do that kind of analysis and, decide whether resources are going more for malaria or HIV, which kills the most, or to other diseases. So it requires for civil society to be able to advocate and convince decision makers at national level. We have to bring this data from the districts, and budget tracking has been one of the tools to do that.
Great. It's really excellent to hear some of those specific examples, because I think there's an increasing participation and interest of many civil society groups in that budget tracking. It was also good to hear you say, and interesting in Mozambique, that the sort of reduction of global donor support has forced and put some pressure on increased domestic resource mobilization, and that's perhaps the best thing that could happen. So thanks for those interventions about how you sort of then track and hold the government accountable at different levels for actually ensuring that money moves in the right direction. There's another question here coming in from someone who's working on implementing a reproductive, maternal, newborn, child, and adolescent health and nutrition UHC social pact in Tanzania. And Denise wanted to know about how you ensure accountability, alignment, and consensus within a social pact on the advocacy road sort of towards achieving UHC.
Thank you. I think this is a very important and difficult question. One of the major difficulties in Mozambique has been the fact that there is a divide between civil society and the government and the Minister of Health. And it has been very complicated to advocate within the Minister of Health for increased resources towards universal health coverage. So we have came to a conclusion as well that it is very difficult for the Minister of Health within the government to advocate for more resources. So it is one of the strategies to work as partners with the Minister of Health and advocate within the government, Minister of Finances, for more resources. And I must say that we haven't succeeded exactly in doing that in a sustained way. We have done that, and we have achieved very, I won't say insignificant wins, but some wins in terms of increase of the health budget. So in terms of, I don't know if I understand your question around the legitimacy of CSOs in terms of state capture, but that's definitely one of the issues that I mentioned that we face is a co-option of civil society by the government. And I think that the institutionalization of the community scorecard within the Ministry of Health national programs is one way of asking to what extent that risk is going to happen. So what we are trying to do now is to say, okay, we understand that you have institutionalized the community scorecard as a social accountability tool within the government, but we want to have the leadership, the lead in implementing. We want to facilitate communities' engagement in monitoring the quality of the services they're getting, so that communities have leadership and they can make sure that their demands are taken into account system. But the issue of factor is very critical in institutionalizing, some of the social audit tools within the system.
Right. Thanks. I actually wanted to pose that question that's coming in from Tom Barker to Walter as well, because you talked, Walter, about the importance to work sort of beyond health systems and to take a longer term approach to tackling the sort of structural impacts on marginalization. And I think this is an interesting question as we are coming towards the end of the conversation, to think about how we do a longer and more sustained engagement with state actors, what that means for the capacity of CSOs and for civil society organizations sort of maintaining that advocacy space. So Walter, could you speak to that a bit? If you also have a moment to talk about good strategies for how you worked with the media, you mentioned sort of sometimes needing to do that naming and shaming. It would be great if you could address that as well before we wrap up.
Yes, first on the logger engagement, I think one of the problems that we have as civil society organization is that depending on these short-term projects, and each one of those short projects, 2-3 years, is expecting that you will change the whole reality in the context that you work. I mean, this is a very perverse situation because we all know that the kind of challenge that we face requires a longer term engagement. So what we have learned as an organization is that although we depend and require these international grants, but that doesn't mean that we restrict our own strategizing to a 2-3 years projects. We have our projects, our grants, but we have also a strategic plan that looks at how we connect with other institutions, public institutions, how we connect with progressive politicians, and how we engage also with specific institutions from the state that has to do with checks and balances, which are very important for accountability. We don't have time to talk about this, but I think it's very important to see beyond the 2 or 3 years project and strategize about how you connect and engage with the different institutions within the states. About the second question about how to engage with the media, I think it's very important from two perspectives. For accountability, strategies that in which you have access to the media are very important in specific moments when you need naming and shaming. Some other times you need to report about a very progressive health worker and official that is fulfilling the responsibilities and duties, and some other times you need to communicate to the broader general public in a different ways. For instance, we have been having a very successful experience with investigative journalists. We have been researching and producing evidence of problems with illegal payments, but we produce papers or we produce newsletters for communities. So we have been good in communicating to academics or to researchers and also with community grassroots organizations, but so far we were not able to communicate to the general public. So what we did is that we started to build an alliance with investigative journalists, and we have been providing small grants so they can go to the field and do the investigation based on the information that we are gathering about illegal payments. They have been producing investigative reports, and because of the quality of the reports and also how respected are these journalists, they have been printing in national media. So all of a sudden, with our publication, we were reaching 2,000 downloads. And the reports done by the journalists, after 2 weeks, just by the online version of the newspaper, it was 80,000 downloads. So the impact of working in alliance with media and with journalists is extremely important. It's very good. And we are just strengthening now our collaboration with more journalists to address different issues that has to do with marginalization and with accountability. If any of you is interested more about this, you can send me an email and I can send you more documents or also these reports that we have been producing together with the journalists.
Great, and that's a very exciting sort of message to end on, Walter, thinking about the broad impact that civil society engagement working in partnership with other stakeholders can have. We've come to the end of our time together. I want to thank you all. First of all, thank and congratulate the team at IDS on this very exciting bulletin. Thank UHC2030 for helping to organize and launch this webinar so we could share some of these exciting findings. There are many more interesting pieces in the IDS Bulletin, which you can access through the links we've been sharing or again through the UHC2030 website. We're also providing here, if you have specific questions, if you want more information on what you've heard today, the panelists have been gracious enough to let us share their email addresses if you'd like some additional information information from them. If you're joining the call and you are from a civil society organization and would be interested in participating in the civil society engagement mechanism of UHC 2030, we very much invite you to get involved, to sign up to participate with us. Our email address is there too, so you can send us a message. And again, we are missing Laura Brearley on the call today from the UHC 2030 core team, who focuses specifically on accountability, but we want to thank her in absentia for helping to bring this all together, and thank Marjolaine and the team at UHC 2030 for helping to provide the technology. Finally, we really want to thank all of you for engaging, for joining us today, for being a part of this conversation, and we do encourage you to share the bulletin as well as the recording, which will be available on the UHC 2030 website in coming days with your colleagues. And we hope you'll join us again in the future for another one of these webinars to talk about the importance of multi-stakeholder engagement on the road to UHC. So thanks again and have a good day.
Thank you. Thank you so much.